Dr. Wael and the group, we can see you very well.
Assalamu alaikum. Yeah, good morning, everyone. Do you see us?
We do. Can you just go ahead and introduce the group over the
Sure.
case before we start?
Sure. So first of all, I would like to welcome you guys with us today from King Faisal Cardiac Center, Jeddah, National Guard. And I would like to thank the Gulf Intervention Society meeting committee for the invitation. We are very happy to be with you today. Without further detail, as Dr. Fawaz said earlier, our case is a TAVI case. We're going to use the Evolute valve for this patient. I will introduce my wonderful team who with me since the morning preparing for this case. We'll start from my left side, anesthesia, Dr. Hisham Amjad, Shahada Sharif from Medtronic, Yasser Awais from Boston with the Sentinel, Rickson, Paolo, Uluf, Vivian, Thuraya, Jeff, Fatma, and of course the two heroes of today, Dr. Abdullah Saidi and Dr. Rasha Bawardi. We're going to go ahead now, Fawaz. We'll start give you the history and examination and to let you know our patient today with Dr. Abdullah. Go ahead, Abdullah.
Okay, thank you guys for having us today. Do you see my slide? Next, please. Okay, Dr. Fawaz, do you see my slides?
Yes, we do. Yeah,
okay.
Just go.
Next, please. So our patient today is a 67-year-old male known to be an ex-smoker. He's known to have hypertension, dyslipidemia, severe COPD with FEV1 less than 25% of predicted. He came to our attention because severe symptomatic aortic stenosis. He came to us with syncope and dyspnea and exertion, NYHA class 2. He's currently in medications that include perindopril 5 mg, aspirin, rosuvastatin 10 mg, and Sympicort inhaler. So in physical exam, his weight is 92 and his height is 169 centimeter. His BMI is 32. Blood pressure is 110/70 and heart rate is 65 beat per minute regular, and he's saturating 97% in room air. Physical exam showed severe aortic stenosis based on the ejection systolic murmur at the right upper sternal border. And physical exam also showed no evidence clinically of side heart failure, but there are bilateral crepitation with his underlying COPD. His lab showed hemoglobin 13.4, platelet 180, INR 1.1, BNP 140, and creatinine 102, with estimated GFR of 65, and troponin was negative of 12. So his ECG basically showed normal sinus rhythm with narrow QRS. His ECG also showed basically LVH criteria with the strain barren. Next. X-ray was unremarkable of the chest. Next. So next, I just wanted to run. Next, come on. Good. So his echo basically showed mild LV systolic dysfunction with high filling pressure. The RP was normal. The aortic valve was severely stenosed, trilevel heavily calcified, and calculated mean grade, it was high around 78 with aortic valve area of 0.6, going with the critical aortic stenosis. Coronary angiogram done outside showed non-flow limiting mild coronary artery disease of proximal LAD and RCA. So the cardiac CT, usually we do our calculation with the measurement in addition to the provided by the company. So aortic annulus area was around 500 millimeter square. The parameter was around 80 millimeter. As you can see, there is at least moderate calcification involving the left coronary cusp. And actually, the calculation of sinus of Valsalva showed adequate measurements. Next. So the LVT measurement below the valve hasn't a significant change. And you can see also we did a calculation for the membranous symptom length. It was 8.9, indicating low risk of conduction in this patient. Next. So the coronary height in both sides, actually the left main around 15 millimeter from the aortic cusp, and also the RCA around 13 millimeter. Next. So regarding the axis, we found the patient has infrarenal abdominal aortic aneurysm with a size of 3.5 by 4 centimeter. Both axes in the right and left actually were calcified, but we actually plan to go from the left, considering the size of the left femoral is a bigger. Next. So this is more detail. Basically, the axis on the right side is small, around 4.3, while on the right side, almost 4.7 to 5.8. Next. So the patient is not frail based on our calculation of frailty index score, and he is a low surgical risk based on Euro score and STS score. It's been discussed in the heart team meeting, and the plan was to go for TAVI, considering his age, COPD, peripheral artery disease, and patient preference. Next. So this is our valve today. It's going to be Evolute Pro. The size is going to be 29. Next. And our intended intervention is going to be transfemoral aortic TAVI. We're using Evolute Pro 29. Thanks.
Yeah. So Fawaz, as you can see, the patient is a COPD patient and with a peripheral vascular disease, age 76. My question to you and your panelist, heart team meeting, give him, is it like go ahead and do TAVI, or still you need to discuss it and see the surgical opinion? The surgeon need to see the patient. What do you think, guys?
Just I will comments from panelists about the case. Maybe.
We don't hear you.
Can you hear me now?
Yes.
Yeah.
Thanks, Mr. Chairman, and congratulate team. This seems like a very interesting case with a number of challenges to the operators, one of them being vascular access with the deglutification that we saw. And my other two concerns, obviously the CT scan informative, but my question to the operators is, even if your coronary ostial height seems favorable and your there is a lot of space with the sinuses of Valsalva, are you concerned bulky calcific disease, which we saw particularly on the short axis on the left and non-cusps, about the risk of coronary obstruction? And the other piece of information to know is if the CT scan gave us information about the length of the membranous septum, and obviously that has significant implications on the case subsequently.
Great. Well, I will answer this question, then we'll go ahead with the case and discuss as we go.
Sure. You want? Sorry, I didn't. You want we answer this question?
If you don't mind.
Yeah. So regarding squishing the calcium toward the left coronary arteries, really we have enough generous sinotubule SUV, and the height is very reasonable. If you're going to use a balloon expandable valve, that's going to be probably a concern, but with self-expandable, it's not that it is there, but it's not as significant as a balloon expandable. Regarding, I have like something here to say that the calcium score is 4,000. That's high, so that indicate that the valve is very tight. The mean gradient around 60, and in such situation usually we pre-dilate, and when you pre-dilate it gives you a hint how the calcium will behave when you deploy the valve.
Great. Tell us about your plan now for the access.
Sure. Let me tell you.
How are you going to close it?
Yeah. So let me, Fawaz, let Rasha take you throughout what we have done so far, and then while she's talking you can ask any question and you can comment, and we see if your panelists and team have other like approach. Go ahead, Rasha.
Good morning, everyone. So as you saw the case, we started with right radial axis for the Sentinel device. We started the left radial axis as our second axis. and left femoral given how you saw the femoral axis on the right. As far as venous axis, we went right femoral and placed a temporary pacemaker. So our initial plan was to consider peripheral ballooning on the left side, but we'll show you the images of the left femoral arteriotomy site. And Thuraya, if you can go through the, go back just one, yeah. So overall good arteriotomy site. If you go forward, you can see the concern was actually in the ostium of the external iliac. Go forward.
Next, yeah.
And on actually angiography, it doesn't look that bad here. I think there was a dropout in our CT, and the diameter looks here actually bigger. So the initial plan was to go with a dilator. If it goes smoothly, we wouldn't actually balloon. So we went forward with ballooning, with the dilator. Go forward with the dilator. Forward all the way to the dilator.
So we use the dilator to navigate, to give us an idea if the 16 French will be easy to go or we need to pre-dilate. In fact, it went very easy. Go ahead.
So we followed it after the dilator. We followed it with the sheath without any difficulty. So there was no need to balloon that external iliac. So after that, the plan is to go for a sentinel device. But before we do that, we can ask the panel what they think about using an embolic protection device.
Fawaz and your panelists here.
Maybe a comment from a panelist about a cerebral protection device. So, Dr. Lahmar.
Yeah, I mean, it's, thank you for inviting me. It's certainly, there's no evidence behind any cerebral protection in any TAVI cases. We've seen this from the US, from Europe. The evidence is not there yet. As we always say, it's better to be in the filter rather than to be in the brain, whatever debris is. And we all, I think, we've seen many times, debris comes out in the filter. What happened to those cases in the long term? I think we lack some data, but I would use certainly Sentinel in these cases. One thing I want to comment on the pre-dilatation. I think for those heavily calcified leaflets, pre-dilatation with a small balloon is a technique DGA uses quite a lot in terms of seeing how the leaflets, they behave in terms of coronary arteries. And I think it's a test how your leaflets might behave for the future. As I said, small pre-dilatation will give you a lot of information before you deploy your...
Sure.
We'll take show of hand about pre-dilatation in this case after you have the data. Who gonna pre-dilate this case? Well, we have a good quite a number of people, expert here. They will pre-dilate the case.
Sure. So for me, Fawaz, pre-dilatation, there is few indication. Heavily calcification, for me, if there is total of like 2,000, 2,500 calcium score and above, I will pre-dilate because, especially with evolute, because we implant high. We use the commissural, the cusp overlap. If you decide to implant high, if you don't pre-dilate, then it will be a problem. You need to, the risk of both dilatation will be higher, and, risk of embolization is higher. The other thing is I pre-dilate if there is nodularity, a chunk of calcium in one cusp. I also pre-dilate in bicuspid aortic valve. Regarding the how we choose the balloon for pre-dilatation, we use the minimum diameter of the minimum diameter of the annulus, which is here. It was around 22, 21. So we're going to use the balloon 20, crystal balloon 20 by 40. Regarding the Sentinel, I agree with Dr. Al-Ahmar. Yani there is a numerical benefit, but there still is not statistical. There is a 40% reduction of the MRI finding with the use of Sentinel. But again, on long term, what this can be translated to, we don't know. But we see a lot of debris in patients with TAVI. I use it if there is a lot of calcium. I use it if I gonna pre or post dilate. I use it for valve in valve. I use it for atrial fibrillation patient because I believe when you pace and there is an appendage clot, as when you do, like with mitral or mitral clip or mitral balloon, I think this is the clot, it can move. And this explains that atrial fibrillation is independent risk factor for procedural stroke. What do you think, guys?
We'll allow Dr. Rasha and Dr. Abdullah to continue the procedure.
Sure.
Then
So
we'll discuss as well.
So we're gonna deploy now the Sentinel. It's already prepared. Put it in front, guys. Here, put it in front. Prepared by Yasser from Boston. As you can see here, there is a 14 wire. Can you zoom?
Oh, that camera.
Up front, and it's curved to navigate through the radial. Now, Rasha, she's gonna pull the wire a little bit inside. And do you see it now, guys? Do you see it? Push the wire.
Yes, we do.
Advance the wire.
Towards the radial.
Yeah, and then we'll follow it up here. Just a quick comment on the cerebral protection devices. As mentioned, there's the previous data that it's not doesn't lower stroke, but there is actually a recent TVT registry data that showed, although their initial analysis of 123,000 patients going through TAVI in the TVT registry, there wasn't a drop in clinical stroke. However, in the propensity score matching, they did see a drop in about 18% in the in-hospital stroke. So we still need more data, I agree. But I think in some cases it might be helpful to do it with a high calcium score. So
go LO 20.
We'll try to put the wire in the ascending here if we can. If we can't, we'll just drop it. So this is the proximal filter that will go later in the... One second.
Yeah, you are right. Okay, you see now, guys, we navigate through the right. You see the coronary wire? It's in the ascending aorta. The distal 2 marker, they need to be in the mid ascending here, like this. And now you see the marker, the most proximal marker, that's the filter.
So first step is going to be deploying through 1.
Here, because the tip of the... So we did, initially, I will show you something, show us the injection. We do injection in the aorta at the LAO side. Show. You see here, we just give 10 millimeter contrast. You see the tip of the big tail, it's the opposite to the tip of the endotracheal tube. Just keep it looping.
Sorry, go back, Thuraya.
Keep it looping. You see? So that is the tip of endotracheal tube, which is near the tip of the big tail, is the entrance of the right brachiocephalic into the aorta. So we're going to start to open the first filter about 1 centimeter above that tip of the endotracheal tube. Go live. You see the endotracheal tube? Is good.
Just coming back.
Fawaz, do you see, Banalus, do you see the tip of the endotracheal tube?
Yes. And we'll follow it with you. Here.
No, you need to push it a little bit.
So the first filters are...
So the first one is open, the first filter.
Come back just a little bit with the wire.
Number 2.
Yep. So we're trying to flex, and then after that we will...
So that's number 2.
Advance the wire, move the whole system so we can rotate it.
Good. Yalla, push the wire.
Now we can try to navigate with the wire.
Usually I pull a little bit.
I'm going to let go of the flexion just a bit because it's over.
Yalla, push the wire.
Yeah, pull now.
Yeah, push. See where it go?
Yep.
Okay. So you see now it went to the left common carotid. You just pull the entire system as Dr. Bawardi doing. Now you are straddled. Now you go to step 3, where you open the...
Can you fix the wire?
The distal, push. Protection device. That's good. So what I do at the end, Floro?
Excellent demonstration, Dr.
Yeah. So what we do at the end, just like push and pull to remove the tension little bit, like 1 or 2 millimeter. Okay. So we leave it now and we cover it.
Do we have one of those?
So next, guys, do you see it? It's like 3 step 1, 2, and 3. Step 1, you open the first filter about 1.5 centimeter inside the right brachiocephalic. Then in step 2 is you do clockwise on the hub number 2. It will rotate itself. If you need more rotation, you rotate the entire system, anterior, posterior. It will direct itself to the common carotid. Then you push the wire further. Then you do step 3, which is deploying the distal filter. Now we're gonna go with the balloon dilatation, guys. So we crossed. Go to a co-planar view, guys. RO view. So usually when I put the confida wire inside the LV, I took the RO, which is nicely profiled the left ventricle. Are you doing the same thing, guys?
Can you come? Sorry, we'll just go Elio to drop the pigtail first. And then
Go, Elio.
Fawaz, do you hear me, panelist?
Say that again, so ready. Well,
Yeah, so to put the confida wire, I go RO 30 to profile the LV. Do you do the same, guys?
Yeah, I think that's what we do. I mean, any view that shows you the LV nicely, sometimes the RAO, or any view that shows you the apex to make sure that your pigtail or confida wire sitting comfortably, looping upright is the way we do it.
Okay.
So I have a question.
Go ahead. Do injection to co-planar.
Back to the risk classification here in this case. So this is a gentleman with F1 of less than 25. So that's a gold criteria for
AP crania.
I'm just wondering, is it considered a low risk patient with this bad COPD?
So based on STS, he's considered low risk, but he also has PAD and COPD. The patient himself actually even refused to have surgery. So, ready?
Inject.
so tell us what you are trying to do now.
So we're gonna do So we're gonna do the simultaneous gradient, as you see, is about 85 to be gradient. We are just doing a root injection here. As you see, the big tail coming from the left radial, because we use the right for sentinel. The right femoral is significantly diseased, so we did not use it. The device from the left femoral, and the pacemaker right femoral vein. So we just did an injection, and you can see the big tail in the right coronary cusp, not in the nun, and we're gonna try now to reposition.
In the meantime, we can go Ario. Just
Dr. Al-Ahmar, do you always cross with the big tail and try to do simultaneous?
I mean, out of the procedure, probably I don't think it's unreasonable. You're going to need the pigtail in the LV at any. I think one point he made it very clear that there is a better access to get into the nerve cusps as opposed to any other access, right radial or wherever you put tail from. Doing the gradient at the start, I think, is just a complementary to give direction.
Yeah, good. So
we used to do it at the beginning of the like years, but nowadays we don't use it as a practice.
Slowly. Yeah, I usually do it because you know, like when you try to publish something, you have all this figure, you want to correlate this and that, and you know, we do TAVI like in different centers, so it's nice to keep track with all this, you know, if it's very important to publication. I learned this from the German.
Yeah, sure.
The German, they usually do it, and they usually use it for their publication.
straighten.
You don't need this.
And I think doing this, we have to pay attention to the deed, making sure that the leveling is appropriate, making sure the lines are well flushed, connection is.
Be careful,
so the data that we're getting are reliable and accurate.
Okay, now it's in the.
Yeah, I agree with you. Usually we zero and we equalize and do all this, you know. I am from adult congenital background, so this is very meticulous in our cath lab, even the level and.
Before we cross,
yeah.
let's.
So now we are going with the crystal balloon for pre-dilatation. As you see, the wire is not pointing upward. His LV is too small. We tried our best, and it's not working. I'm gonna keep the big tail for injection in the ascending aorta, so we can inject while we are inflating to look for the coronary, how it behaved, the calcium. That's all the piece of information, as Abdullah said, al-ahmar.
What is your size of balloon here?
20, which is the minimum of diameter of the annulus on CT, not the average, the minimum.
Who's pacing?
Pacing?
Who's on pacing?
Pacing. Yeah.
Yalla. So, did you cross?
Not yet. Wait for everything to be ready.
Yeah.
So typically we try to make sure everyone is ready before we cross with this critical AS.
Yeah.
All right.
Ready,
Okay,
pacing?
crossing now.
So we are crossing, it's going easily. Yeah, it's nice
Yeah.
here.
Yeah.
Good.
Pull the big tail.
We can pull it.
Good.
Okay, yeah.
So be ready for injection. When I tell you inject, inject.
Pace.
Okay, I gonna give the command, guys.
Good.
So be ready. 1, 2, 3. Pace. Up. Down. Inject. Inject. Okay.
Oh.
That's fine.
Good.
Stop basing. Stop basing. So show us, guys, what pressure.
We have
Show me the cine.
no change in conduction so far.
Are we sure the pacemaker is in the right position? Because it looks, usually see it in the...
Is your pacemaker in a good position?
Yeah, it need a bit, but it was working. It was pacing. Slowly.
Yeah.
I'll come back.
Come
Wait,
back,
can you come?
yeah.
Ari? Oh,
Epi,
sorry, Ari.
Epi, go ahead.
No, it's okay. It's okay.
Slowly.
Ari.
Inflate the balloon. Slowly. Okay, good.
Yeah. Now this looks like more stable.
So,
position.
Yeah.
yeah, good. Show us the injection, what we just did. Yalla, go RO 30.
Take the balloon out.
RO 30. Show us the cine, the balloon, just. You see now, is nicely, no waste. Yeah, you see at the end we give the injection, unfortunately not from the beginning, but you can see you see if you focus, the coronary is up, and there was a generous, let it go.
Sorry, go ahead.
Guys,
Sorry.
do you see it or no? Let it go, guys.
No, we can see it nicely. Do you have any
You
change
see,
in
you see,
hemodynamic?
no, you see
Or-
the injection? You see the injection? So there is a very nice, spacious sinus of Valsalva, and the shunt of calcium is way below the ostium of the coronary. There is no II, the tracing form. That's a very good point for us to comment. The tracing is beautiful. The diastolic blood pressure is the same, no change. Okay, remove the balloon.
Yeah. Walk it out.
Okay, any comment, guys? Any questions so far? Is it everything clear?
Yeah, Faisal Gofi has a question.
Okay, good. Where?
Go ahead, Faisal.
I have one. Can we
Be
check
careful
it
the
out?
wire, guys.
Yeah.
Mic is
Let's
not
test the
working.
valve, guys.
Can you
If you're
give
ready?
Dr. Faisal a mic?
يلا باشا. Good.
You have to adjust the value or the big tail.
Yes, we'll check the valve first.
Just so we'll go step by step, guys. Fix
Dr. Faisal.
fix the big
A
tail.
tough case with heavy calcification, but may I just ask the group, why did they pick the RAO projection? And the second part, we are seeing clearly a big calcified valve. Are you happy with the one, or you think the balloon had a waste at the end? But this is the case with this amount of calcification.
Well, Faisal, I did not hear the question.
Test.
Why would you pick the RAO view? And the second part is, would you believe the balloon give you the inflation that you wanted to valve, or would have you gone for a second inflation with a slightly bigger volume? Because at the end of the inflation, there's still a bit of a waste with this calcified valve. Just judging by if you're going to end up with a gradient post-deployment.
Yeah. So
Dilatation technique.
yeah. So Faisal, this is a
More
crystal.
aggressive might reduce your chances of post-dilatation.
Yeah. So this is a crystal balloon, semi-compliant. Usually the 20 by 40 it take 19 ml of contrast. Me, I go 23 to 24. So my inflation, it is even if it is single, it is really very effective. You have, like we do a lot of balloon dilatation, like for different reasons. So the crystal balloon, we exercise it. Sometimes we add 2, 3 ml and we test it. We found that the crystal balloon, it can go the diameter high with more volume or more pressure. So that was a good inflation with no waste. I feel it's a good inflation. It just to give you
just with the taken opinion of our panelists who's happy with the balloon, think that we need to repeat it. Just one word. Hatem, happy with the balloon?
So I think that this part of the procedure emphasizes dilatation. It goes beyond focusing crossage of the valve. And
if 2,000 of a balloon, 2,000, 2,000, good. Repeated one?
Across the LV.
Sorry?
But I think a better projection to help you understand how the calcium in the leaflet migrates at its proximity to the ostia will probably be the projection. But even though the jury is still out on pre-dilatation, the most recent direct randomized control trial showed a difference. But in by case basis.
In this case, you're going to repeat it or you're happy with it?
It's I think that's a decent result.
Okay, Dr. Ahmed.
Quite happy with the pre-dilatation. To oversize it, don't need one-to-one because you risk an acute regurgitation those patients for hardly any benefits. And I emphasize when you pre-dilate, have the DAV ready for you anytime. Could render the patient hemodynamic stable. I think they've done a perfect job. And I tell you, Dr. Hatem, the view you need from rotation, the behavior of the leaflets, and I think particularly for the left main will better image of how the left leaflets behaves in correlation with the left main stem.
Start to load.
Taking into account the minimal dimension, I think this is enough for now. And we saw, I'm not sure I saw a significant waste there, but I think we'll see how the valve goes in and then if needed in post-dilatation.
Yeah. So can I add something?
Adel Tash is a cardiac surgeon.
Oh, go ahead.
Ready?
Dr. Adel over dilatation with the balloon.
Lower the table for you.
Give us the valve, please.
Let me help you.
Okay.
The valve.
Like balloon dilatation with cases.
Make it straight. Make it
3 o'clock.
فلورو just فلورو.
No yet.
Just hold on. دخل شوية من الديفايس.
Hold on. So, yeah, why?
3 o'clock. 3 o'clock. عبد الله غير hold it up في الهواء.
The heart team meeting. If you don't mind.
Yeah, we'll do it at the end kindly if you don't. Yeah. So we'll allow it to continue now.
So just let me add one quick thing. Turn the light on. Let me tell you something, Fawaz. If the patient having severe LVH like this patient, do the minimum with the balloon dilatation. As I like the comment on if acute AI or a new moderate AI happen with this small LV, there will be very bad situation. So it just, you know what, it's 20 with a good inflation is enough.
And as mentioned by Dr.
Hatem, the valve, I think you guys are great on cusp overlap and commercial alignment. So just take cusp.
Okay. So guys, now give me the light, please. Now we're gonna introduce the device over the wire to the LB. Before we used to just introduce it at 12 o'clock. The flush port, you see it here? You see my finger here? You see this, guys? Zoom?
Yes.
So Gilbert Tang and Dr. and the other groups, they found if you put the flush port at 3 o'clock, you will have a good chance that you're going to have a commissural alignment. So when we say commissural alignment, simple wording, keep the flush at 3 o'clock and introduce your device and keep eyes on that 3 o'clock. So that's the first technique we want to show, the commissure alignment. While we are going inside, there is some evidence will show it you that it will show you that you are in a good commissure alignment. Basically, the hat, it's a small shape at the tip of the catheter. We'll show it you now. If it is on the greater curvature as a line, this means you are doing good job. If you are in a cusp overlap, it is on face, like in front of your face, like a square. This means you are obtaining a good commissure alignment. So now we'll let Abdullah and Rasha go ahead and advance the device. Abdullah will keep the flush at 3 o'clock, and Rasha, she will push that. Eye on the, now it's very important to keep eye on the abdominal aortic aneurysm, because if the wire is biased and it go to the aortic aneurysm wall, then will be
slightly down. Just keep the wire in the
complication.
Yeah, good. So there's no resistance going into the iliac. We already passed and we're in the descending aorta. Okay. Going up slowly.
Wait,
wire.
Keep eye on the wire.
Yeah,
and it's at 3 o'clock. Yeah, go ahead. Straighten.
Okay, good.
And as you can see, go LAO, because we're gonna go across the aorta while the sentinel is there. So you have to go slowly and carefully.
Make sure no interaction here.
You see, and there is a calcium at the arch of the aorta. I wouldn't do the case without cerebral protection, to be honest.
Pull wire back. Just
okay.
Pull wire.
Yeah.
Pull the wire.
Pull wire. Can you pull wire?
Yeah, pull.
Push. Push.
Okay, now
good.
It's good.
Push.
We
are crossing. Good. So that is the co-planar view. That's co-planar view.
Cranial 4.
So I will show you how we do the cusp overlap. So we go first to the co-planar view, the one we use for Edward. And I do a quick injection there, just to figure out where I am now, and to make sure that the big tail in the non-coronary cusp. Inject. So now we are at the big tail in the non-coronary cusp. Then I will go LAO caudal to make that ring as one line.
LAO first. LAO, please.
More.
Come caudal now.
That's good.
Good.
Looks good.
Okay, so that you see, very important. You see this view, guys. Fawaz, panelist.
Yes, we were.
Just continue.
Careful.
You see the hat I'm talking about. It is toward the big tail. It's toward the greater curvature. You see it as one. It is below the ring. You see the ring is one line. There is something like a ship below. That is against the greater curvature. This means you are doing good in terms of commissure alignment.
Now we'll move to the cusp overlap.
Okay.
Yeah.
So now we're gonna move to the ariocaudal, which is a cusp overlap. It's a pre-specified number based on a soft wire to be done by the company, where you put the left and the right coronary cusp over each other, and the non-coronary cusp in separate direction. So now this is supposed to be the cusp overlap view, RO 29, caudal 17. But you can see also, before I do the injection, you can see it's still the ring is round, is not one line. So we'll go a little bit caudal to make it in one line. Go ahead. Go. Okay, stop. Do you see this, guys?
Yes, we do.
So that is how you...
Didn't on the aortogram or CT to identify you for...
it is by CPU at the beginning, at the mid of 2019. I used to use two big tape.
In this case.
It's based on CT. In CT.
Okay, Flora?
Do you see, guys, below the marker there is a shape, rectangular in shape. Do you see it, guys? Like a teeth, like a rabbit teeth.
Okay.
Guys, do you see it?
No.
So that is toward your face. That shape, this means you are so far doing very good with commissural alignment. In this view, if you are not having this chip in front of you, you're going to pull the device, you do counterclock little bit by 10 to 15 degree, and you go back. That chip, it will be central on fast in your face, not toward the greater curvature. Now, as you can see now in the angiogram, let the angiogram run.
Back to the back.
Just the angiogram, let the angiogram, the last one.
Maybe the cameraman, instead of having the picture with your hand, you go post us some hemodynamic while doing the case.
Do you see the angiogram and hemodynamic, guys? Just the last scene here, Turey.
Yeah, this is it.
Yeah, so this is the cusp overlap view. You see all the chunk of calcium over each other on the right and left, and you can see it overlying each other very nicely. Two arrows, one up, one down, and you can see the non-coronary cusp is far away down. So we're gonna go ahead about 1 or 2 ml below the non-coronary cusp. Go. Push.
You have wire?
Yeah.
Yeah. Okay. Push. Okay.
We can start here.
Okay. So we're gonna start releasing here. Everybody in the room listening carefully to our command. So that wire, we pull it, we make it coaxial with the device, no tension. And we're gonna release the first 1/3, then we're gonna start to base in the second and third thread. Just come Ario a little bit, guys. Just Ario a little bit, Ario. Okay, stop. Okay, so you see, don't be deceived by the big tail. There is a chunk of calcium about 2 ml below the big tail. So we need to go a little bit deep, little bit, at it. Go push forward.
Slightly.
Okay, we'll start to release now.
Go ahead,
Rasha, she gonna maintain, and you're gonna be ready on the injection. You be ready on the sphere.
I'm releasing now.
Yeah, release.
So a slight forward tension, since as the
Release.
mentioned, the calcium is below the pigtail.
Abdullah, you release like this.
Yeah, sure.
Sure, let me.
What is the key doing? Is there any block there?
Sorry?
No, it's
Can you have a
nerve
hemodynamic? Can you see?
Yeah. You can get the screen to be transmitted.
Abdullah,
have
just
it?
release.
Sure.
Okay.
We're gonna release, pull. You see the device, we are a bit deep.
Okay, coming back slow.
Yeah,
Yeah.
good.
Okay. Slow down. Okay,
Very
go ahead.
good.
No, it's
Pull.
jumping.
You see it keep coming in. I'm gonna pull the wire a little bit, release the tension. Good. That's
Coming
keep
back.
it there. Keep it there. Test. Okay. Keep it there. Pace. Make it 60. Test.
Slight negative back tension.
Okay, stop pacing. Okay.
We have pressure.
So we are good. Pressure is good. Let him recover. Okay. Pressure is good.
Anything
Give me
happen to
pressure.
the ECG?
No, nothing. It's sinus
there.
narrow complex. Pressure is good. So are you full now? We're gonna fill the power injector. Go. Just do dry cine. I will show you something. Do dry cine. As you can see, we are below the big tail. There is 2 millimeter chunk of calcium. We are about 1.5 to 2 millimeter below, and you can see the cusp. There is no parallax. All the teeth of the valve at the end, they are parallel to each other. Do you see it, guys?
Yes, we need an aortogram to evaluate the depth.
Sure, we'll do it. So we're gonna do an injection now, Sini.
Dr. Wael,
Yes, sir.
it'll be nice for the sake of the audience to show what the position looks like in your cusp overlap view compared to your standard coplanar view.
Sure.
And
So
how these two are different.
Yeah,
That is if
so-
your patient is stable.
yeah, it is stable. So I will show you now. This is in the cusp overlap. If you see here, you will see yourself like about 2 millimeter below. If you go iliocaudal, go to the position number 2, go iliocaudal, fluoro, Russia, fluoro. Just go ilio.
When the ring was
Okay,
closed.
slowly.
I think LO
Do it under
17.
Cine. You see here, you are too deep. It look you are too deep. Too high. Just do an injection here.
Ready?
Ready.
Inject.
You see, you see that the big tail is a bit pulled back. You see, you are like about 2 millimeter below. Usually in these circumstances, you will not release it. Don't move. You will not release it here. You will be afraid. But I am confident because I saw it in the cusp overlap. Okay. Pull the pigtail. I will continue the release here, guys. Pull the pigtail. Just forward tension. Pace. Forward tension, little bit. 180. Okay.
We have 5 minutes to finish.
Okay. I release the device. Okay. Release the tension. Release the tension. Okay. Stop pacing. Stop pacing.
Store the fluoro.
Fluoro safe. Yeah.
Okay. So now we release the valve. As you can see, there is a waste. Fluoro. Fluoro. And we have a narrow complex with no problem. Now I'm just gonna take this slowly out and we'll do our orthogram and we're gonna do the balloon. Give me a 23 balloon. As you see, there is a waste definitely. Carefully you take this out, prepare the sheet, guys.
Watch.
You have the sheet ready, guys?
Watch the arch. Just
Give us the sheet again. We're gonna use
No, just, it's not like,
wire.
yeah. Okay, so we took this out.
Dr. Wa'il,
Yes.
can hemodynamics on the screen, please, just to see the
Show us, guys, show us
camera on this screen.
show us the hemodynamic, please.
The camera on the screen.
يلا عبد الله. Fix the wire. فلور رشا. Release your hand. Keep pressure. لا ريح يدك.
What do you think
I'm
there is a
out
waste
of
here?
Oh, there is a constraint for sure from the calcium, but we're gonna do it now.
Certainly there is. It's the, I think from this, we predicted this from the start, that this, the compromise, you can tell there is heavily fight. Always a balance between how heavily you weight or you just rely on this, the self-expandable valve to take the space. And those valves land a bit further at some point. Now, a point perhaps across whether we post or not. I think something where we probably you've seen at the TCT, they show the case where they retrieve the valve, a very heavy calcium valve similar to this one. We have ended up with 2 false aneurysms. Although the deployment was really perfect, a month later CT showed 2 large false aneurysms in the root of the aorta requiring surgical correction, removing TAVI and correct the valve. Okay. So I think the jury is out still for post-dilatation, but I think it's predictable that this valve will behave this way.
Pigtail.
Yeah. So we're gonna give you also injection here, guys. Give us the go down.
It's ready. Yeah.
Down a little bit. Okay. Yalla, let's get Sini and give us an injection quickly.
Ready for injection? Yeah.
Yalla, ready.
So there is a paravalvular leak. We're gonna, you see there is a central also from the wire. But we're gonna do balloon now. Give me the balloon. Go RO, implantation view. View number 1. Give me the balloon. That's 23.
Balloon, guys.
23 balloon. 23.
It will be great if we have the we couldn't see it.
You still
Guys, show him the hemodynamic,
can you
guys.
put this camera on the screen?
Yeah.
Yeah. Are you able to move
Not
it to
connected
the
to the system. You can just put the camera on the screen.
Yeah, that's what we're
Put the
trying
camera
to
on the
do.
screen, guys. 20, that's too small. We are getting the balloon. Yalla, that's
Can you see the screen?
You just tell me what is the number? Huh? No, there is no 22. It's
Can
there.
you tell the camera this is not the hemodynamic? The hemodynamic is
crystal
the one
balloon,
on
ما
this
في
side.
Okay, put this. 25
The
is
one
too
in
big.
pink, huh?
لا ما في Underfield, ما في Underfield. Just go with this, please, now.
Okay. Sorry.
Just 1 second. Come with me.
The lower one.
You prepare it?
Come with me, please.
the same one, huh?
Yeah. Just keep
Go the
negative
crystal balloon there.
I think they oversized it.
Okay. You have wire?
لا لا في شفت 23.
I don't think this will go. You don't have a fresh one? It won't
I
go.
think it's not going on.
Yeah.
طيب.
Straighten and take it out.
Yeah, okay, يلا.
So you're going to take for post dilatation?
Yes, we're just waiting for the
What?
balloon.
Yeah,
to
they are bringing the balloon now.
can you guys see the hemodynamics? So there's no change in conduction, sinus.
Right.
PR is short, the QRS is narrow.
And diastolic blood pressure is also
yeah.
60, 65. So.
Okay, so we'll allow you to do so and have some comment from our panelists. So maybe anyone can comment on the case so far. Dr. Abdullah.
82. 2000.
Very well demonstration. I think,
Come.
as my colleague mentioned, the heavy calcium was something difficult to tackle in this case, and as a result, we saw the underexpanded frame. Fully agree with the post-dilatation here. I'm not sure if go aggressive with the pre-dilatation would have prevented what we saw. I'm not sure exactly. So
Well, this is to be honest a common scenario where you see the waist, but we're gonna do now both dilatation with 22 balloon, and I like to go sequential. If it's not working, we go a bigger balloon, but I'm quite sure this will be one. Look, he's very hemodynamically stable. Blood pressure 101/60, narrow complex. Guys, quickly.
Yeah, what's interesting with the direct trial, there was no difference, as you mentioned before, in terms of stroke, in terms of pacemaker, in terms of mortality. There was a difference in terms of post-dilation, 50% reduction post-dilation. But even with the pre-dilation, there was about 10 to 15% who needed post-dilation.
Go negative, huh?
Guys, I have to finish the case in 5 minutes. So
No, we will do the balloon in yeah. So if Fawaz, 5 minutes will be enough. Will be enough.
We have
Go, guys. Go. Be on the pacing. 180. When I tell you. Yeah.
Dr. Al-Ahmar, did TE is usually moving just sedation and transthoracic. In this case, do you think TE presence would make a difference? Could check for paravalvular leak and grade?
It's a very good point. I mean, a few years ago, every procedure was done under TE supervision. At the same time, the paravalvular leak, where the location, the anatomical, it could help you a lot in terms of deciding using.
Guys, we're gonna go up with the balloon, as you can see.
I think it's useful.
Pull little bit, pull.
I mean, they're doing very well. The diastolic pressure is than 20. The everything is hemodynamically perfect. I think it's to see these changes. And sometimes you allow the valve to extend 5-10 minutes and repeat the without doing anything, and you will see a difference.
Store the floor.
So it's open better than before?
Yeah.
So this is size of 22?
Yeah. You see now that's the inflation. Like I popped my jugular vein.
Maybe you would
watch the
okay. More. So let's just do an injection here. Magnify, please. Magnify. Okay, good. Yeah, the wire. Okay, the wire went out. That's fine. We're gonna engage again if not working. Yeah, ready? Beautiful. Mild AI. Do you see it, guys?
Expanded well, no more about leak. I think it's the waist.
Look at this. It's just mild AI, and the give me guys lift floor please. And there is the hemodynamic. Look great. His blood pressure, like aortic pressure, 116/60, and normal sinus rhythm. Very good implantation level. I'll give you another injection, guys, with 20 cc or 15. Make it 15.
So that will be the last for the case. Just
If you give me 1 second, I will try to engage and show you how we engage. Give me 3.5 lift Jetkin.
Do you want to do it from here?
Yeah, from here. Yeah. Give us the injection. Ready? Ready? Okay, guys, ready? Yalla. Inject. Look at this. Barely mild, guys.
Thank you very much, and the group. It's a great case.
Fawaz, I will try to engage while you are talking. Go, go, go.
Do it silently. We'll open some discussions and we'll see the classes again.
Jail 3-5.
So any question or comment from the audience?
Yalla, take the...
Anyone have any question or comment? Okay, great. Maybe Dr. Adil Tashib, you're a great surgeon. Talk to us about
and then we can get the J-wire
in TAVI and different acts. It's your intake about it.
Yeah, I
كلها مسافرين دحين.
our team. Should we discuss
راشد راح
a
تاكل همبرجر
76-year-old people at the SDF and the Euroscore lead them these kind of patients. I think the discussion, first of all, a 7-year-old patient now with the current guidelines, the European, the German, the American guidelines, I think it's until proven otherwise. So this team meeting is not about TAVR versus SAVR. It is a TAVR case. But the discussion is, like in this case, the ascending aorta was heavily, the descending aorta was heavily calcified. There was an aneurysm. You know, there is a lot of access issues that probably the surgeon can and could be you in such cases. I don't know if the percentage of TAVI case, is it due to the big device coming and scraping all the ascending aorta, the arch of the arch of the aorta, and the ascending aorta, or is it the balloon dilatation, or of the valve itself, or is it due to the post dilatation? Where is this of the strokes, and how can we make the risk of stroke by using techniques, alternative approaches? So if we have a very heavily fluorotic and calcified heart, maybe we could use an approach where a direct approach, a carotid approach, where you know where your devices go and what part of the walls of the aorta your device is. So that, you know, that's you know, inshallah that of course, the subclavian, the transcarotid, they have its risks. But you know,
take the sentinel
risk
if you want.
Of complications in a open surgical control technique is quite minimal. It's quite minimal.
So Fawaz, sorry for...
Sure.
So just see at the screen, guys, we just engaged simply without no huge effort. I can do even better. You see there is one cell down, but with the sake of time, that's a straightforward engagement.
Excellent. We really thank you, Dr. Rasha and Dr. Abdullah. It's a great demonstration of a very calcific and access. I think you did a great job by demonstrating quite.
Yeah. Rasha, she will show you how to retrieve the sentinel if you want. Quickly.
No, we are good at this.
Good. Okay, good. Okay, so Fawaz, be nice with the woman in cardiology. Be nice with them.
We cannot get into, but thank you very much. Appreciate it. Excellent job. We'll just allow 1 or 2 minutes for our panelists before we close. Comment on a closure device. What's your preference? And what do you think about it?
The two big devices are the suture-based probe light, newly introduced in man.
You pull the entire
device.
Pull the wire just so you can see the tip.
And I think
the three
the device
number
that
two,
the
the opposite
operator
of
has the
what you
most
are doing.
experience with is probably the best device.
Number two, the opposite.
That one, most people are the probe lights 2 or 1 with additional
actually, push just to give it some time to
collagen plug if there is a need.
Just push it
in my mind, I think
pull the wire.
if you're comfortable and used to the suture-based, probably that's addiction,
It's not,
the fact that you can have still have access to the best if there's any problem arises.
Okay.
This is good enough.
My
You have the
preference
wire, right?
is with the device that I'm most comfortable with.
Full quickly.
Dr.
Take it out.
If you're
Stir the
in
floor.
a center
Take
with
it
the
out
do
quickly.
50 TAVI per year,
let's take this out قبل.
how many devices you should have in your
Let's do
shop?
it,
Should you
please.
go with all the available market or just stick with one
The bacteria out.
Yeah.
TAVI valve?
Final pressure and bacteria.
Jawar.
I think
Because
you always have the options. No single for fit. That's a fact. You should be familiar with every device, with process, know everything about it. As I said, whether you do 50 or you do 200, I think you should know everything about your device, what the ins and out of every single device you use, whether vascular access or TAVI or protection, cerebral protection device. One thing that's been touched on, it's the coronary access. Now we're moving into very young generation. This is a crucial in any TAVI device for the future, to have TAVI access. And still, the new publication showed that there's about 17% could not be accessed the coronaries. This is a scale. Put it in somebody who's 40 years old, TAVI valve, and it comes to you with a heart attack, then it next time access his coronaries. This is devastating. So I think the future for TAVI valves is the coronary access.
Excellent. Any other comment from panelists before we finish? Okay. Dr. Wael, Dr. Rasha, Dr. Abdullah, can we have Dr. Wael voice? Thank you very much. Congratulations on the case. Any final point or words from your side?
Yeah, so first of all, I would like to thank everybody. Patient sinus rhythm, very high implant. We did the coronary access clearly for you. I would like to thank you, Fawaz, and the panelists and all the audience. I would like to thank my team, Rasha Bawardi, Abdullah Saidi. They worked extremely hard. I'm so happy to work with them. The rest of the nurses, Medtronic, Boston, Fatima, Thuraya, Uluf, Vivian, Jeff, and thank you very much. See you tonight or tomorrow.
Do you have the
Thank you very much.
purpose?